Assalamu alaikum. This presentation is on laryngeal dysplasia. Its new proposed name, the laryngeal intraepithelial neoplasia, is gaining acceptance and popularity. Some known or unknown factors can lead to errors in the DNA and progressive accumulation of genetic changes in the laryngeal epithelial cells. This would lead to a clone of atypical cell in the epithelium. Some of these atypical clones could be self-limiting and would be abolished. Some would regress, some would persist, and others would progress into various other forms, including invasive squamous cell carcinoma. The whole spectrum from hyperplasia of the epithelial cells to various forms of dysplasia, mild, moderate, or severe, carcinoma in situ, or to invasive squamous cell carcinoma can be seen in different patients. Sometimes in the two or three of these can be seen in the same patient. The risk factors involved in the process include smoking and alcohol. Both are dose dependent, depending on the duration and the severity of the habit. Gastroesophageal reflux is also implicated. HPV may play a small, non-significant role in the process, but other idiopathic forms are not rare. Laryngeal dysplasia presents almost always in adults and affects men more often. It can present like a whitish or a red patch in the larynx, or sometimes a mix in between. It can affect any area of the larynx, but affects vocal folds much more common, particularly the anterior half of the vocal folds. And it can be multicentric, affecting various other places in the larynx. Just by looking into the larynx by endoscopy could not differentiate between the various forms of this lesion. You cannot, by looking into the larynx, say whether this is keratosis, hyperplasia, mild, moderate, or severe dysplasia, or carcinoma in situ, or even invasive microcarcinoma. The reported rate for malignant transformation for these lesions, the laryngeal intraepithelial neoplasia, is anything between 1% and 40%. But identifying which patients will have this transformation into squamous cell carcinoma is not possible on clinical grounds. The difficulty in the assessment of laryngeal dysplasia is illustrated by this example, a comparative study between the surgeon's intraoperative evaluation of the lesion and the final histopathology report. The overall accuracy was only 65%. The type of the lesion, or the grade of the lesion, or whether there is any invasion or microinvasion or not, was not accurate in about a third of the cases, with a relatively high sensitivity but fairly low specificity. And surgeons would overstage the diagnosis in about 1/3 of the cases, but only understage it in about 4%. Various names were given to the same process: laryngeal intraepithelial neoplasia, dysplasia, atypia, or leukoplakia. All these terms describe the presence of atypical cytological features within the laryngeal squamous cell epithelium. Here there are both morphological and molecular manifestations of a neoplastic process. The atypia, or the dysplasia, is confined by the basement membrane. It should be within the laryngeal epithelium itself, and it should be seen on histopathological examination, like features of a neoplastic process, sometimes combined with DNA ploidy, where aneuploidy could be seen, and sometimes with the use of immunohistochemical methods, which would show overexpression of p53 protein. How common is laryngeal dysplasia? A post-mortem study of the cadavers of smokers had showed that these lesions could be as high as 11% in the glottis and 4% in the supraglottis. Only very few of these lesions could progress enough to present clinically, as the rate of new cases of dysplasia is between 2 and 10 lesions in 100,000 population per year, only a fraction of the cadaveric study. And only a small percentage of the laryngeal dysplasia cases, out of these 2 or 10 lesions per 100,000, only 0.4 cases per 100,000 would have a carcinoma in situ. The pathophysiology of laryngeal dysplasia is primarily abnormal epithelial differentiation within the laryngeal epithelium. There will be atypical cells and atypical differentiation within the epithelium. There may be also accumulation of keratin on the surface, and this will give the lesion its whitish appearance. Sometimes the epithelium would be thickened due to acanthosis, and this would give rise to a raised patch. But some other times there would be atrophy of the epithelium as well. The other feature may be seen in the subepithelial part is the formation of new blood vessels, sometimes perpendicular to the usually longitudinal vessels over the surface of the vocal folds, and this may be an early sign of a potentially malignant process. The change in the appearance noted in the erythroplakia is a combination of atrophy of the epithelium and lack of keratinization. This will give rise to the reddish appearance of the erythroplakia, while as the whitish patches are usually due to accumulation of keratin, sometimes accompanied also with a thickness of the epithelium, acanthosis. Several grading systems were used to classify laryngeal dysplasia. In the older version of the WHO classification, the 2005 classification, laryngeal dysplasia were graded according to their severity into mild, moderate, or severe. In the mild or the minimal dysplasia form, the cytological appearance of atypia is confined to the lower third of the epithelial thickness, the basal and the parabasal part of the epithelium, while the upper 2/3 show normal stratification and differentiation and frequent intracellular bridges. The hyperplasia with no atypia should not be included into the classification of dysplasia. In the moderate dysplasia, these basal or parabasal atypical changes would extend to the lower 2/3 rather than just the lower third, and in severe dysplasia it would be full thickness extending to the upper third as well. When the atypical undifferentiated cells extend to the lower 2/3 rather than just the lower third, then the dysplasia is called moderate dysplasia. But when the cellular atypia reaches the superficial third of the epithelium or extend even full thickness of the laryngeal epithelium, the grade of the dysplasia is now severe, dysplasia and carcinoma in situ. There are some differences between carcinoma in situ and severe dysplasia. Carcinoma in situ would show more aberrant cytological features and more frequent mitotic figures, but for the purpose of management, the two groups, the severe dysplasia and the carcinoma in situ, were grouped together into the same stage and treated similarly. It was noted that in the cases of carcinoma in situ, if immunocytochemical investigations were carried out, there may be breaches of the basement membrane in several areas, indicating microinvasion. There were some issues with the older WHO classification systems and some other grading systems as well. In general, classification systems should allow for a prediction of the biological behavior of a certain grade and provide guidance on the treatment or the follow-up for that particular grade. That wasn't the case with the previous WHO system, because there was considerable overlap between the rate of transformation to malignancy between the three grades and the duration it takes a lesion to be frank malignancy as well. That was the basis for the new WHO system, which basically has the laryngeal dysplasia classified into just two grades: low-grade dysplasia and high-grade dysplasia. The low-grade dysplasia includes only the mild or the minimal dysplasia, and the rate of transformation for this grade is just about 2%, whereas all the other grades, including the moderate dysplasia, severe dysplasia, and carcinoma in situ, were grouped as high-grade dysplasia, and here the malignant transformation rate is as high as 40%, ranging from 10% to up to 40% malignant transformation rate. The inter and the intra-rated variability in the grading of laryngeal dysplasia is well documented. The same lesion can be graded by one observer as a mild dysplasia and by another as moderate, for example. In another example, a severe dysplasia can be graded as moderate by someone else. But it was known that, as a general rule, agreement between pathologists and surgeons in the grading of the system is highest at the two extremes. They would agree very well on what is a very mild dysplasia and what is a very severe dysplasia. And that's the basis for the two-tier system of the new WHO, just low-grade and high-grade dysplasias. There are also some other difficulties in the grading of laryngeal dysplasia, including sampling error. Sometimes the samples are taken from only one part of the lesion, and other parts could show more sinister behavior. Inflammation of the epithelium can also cause errors in the grading, and the variation in the epithelial thickness in various parts of the vocal fold. Sometimes it can be as thin as 2 or 5 layers, and in other parts it can be as thick as 20 layers of cells. So all these would add up to the difficulty in the grading of the laryngeal dysplasia. Using cytology by laryngeal brush cytology is still developing. It's not yet an established way of grading laryngeal dysplasia. A reliable and consistent way of predicting which dysplasia lesion is going to progress to malignancy and which would not would be very valuable in planning the management. Several biomarkers were assessed for this, including several various cell adhesion and regulators, several other genes or several other proteins, altered P53. The overexpression of P53 is known to occur in the early event of carcinogenesis, DNA ploidy, for example, and several other proteins. But the predictive value of these markers, however, has yet to be confirmed in large-scale and prospective studies. Patients with laryngeal dysplasia primarily presents with voice changes. They would require, of course, a full history and examination of the head and the neck. But the patients with a benign keratosis or just hyperplasia with no atypia would have the same signs and symptoms as patients with severe dysplasia or carcinoma in situ. There would be roughness of the voice and strain in voice production with a reduced dynamic range. The gold standard in the examination is laryngeal endoscopy, either flexible or rigid. Better still if can be combined with video laryngostroboscopy if it's available. Anterior commissure area and the ventricles and the undersurface of the vocal folds need to be assessed, and these can be assessed with various angled rigid laryngoscopes, for example. Trying to distinguish between a low-grade and a high-grade laryngeal dysplasia can be improved by the use of the bio-endoscopic techniques, such as the narrowband imaging system or the SPICE system. This will show the architects of the blood vessels in the subepithelial layer and high precision photography of the laryngeal epithelium. If certain abnormal blood vessels are seen in the vocal fold subepithelial layers, like intraepithelial papillary capillary loops or vessels perpendicular to the usually longitudinal blood vessels on the surface of the vocal folds, this may indicate some potential for malignant transformation. The accuracy of such systems of the bioendoscopic techniques is quite high. It's about 83% for sensitivity and 98% specificity for the narrowband imaging, and quite similar results for the SPICE system. Laryngeal stroboscopy, if it is available, can be of help in defining the depth of the lesion. It can show whether the lesion is restricted to the intraepithelial part and can move freely with the mucosal wave, or it has some deep invasion into the lamina propria. And this would be of help in the grading and in the management of such lesions. If the lesion is very superficial, limited to the epithelium, then it will give the appearance of a boat riding on a wave during stroboscopy. But if there is any deeper invasion, there would usually be involvement of the mucosal wave and the vibratory amplitude of during stroboscopy. The mucosal wave would stand still at the part which is relatively fixed to the lamina propria. The management of laryngeal dysplasia should start by a trial at reducing the risk factors. Medical treatment currently does not have a significant role in the management of laryngeal dysplasia. There were reports of some benefit from aspirin, metformin for non-diabetics, retinyl palmitate and folate, but there is no solid confirmation of benefit. The reduction of the risk factor should start by trying to stop smoking. However, if the lesion had reached the grade of severe dysplasia or carcinoma in situ, the lesion may be irreversible. Before that, in mild and moderate dysplasia, there are reports about lack of progression and sometimes reversion of the lesion after stopping smoking. However, stopping smoking is useful to prevent further recurrences after the initial treatment. Alcohol should also be reduced or stopped. Laryngopharyngeal reflux should be treated. At this stage also, the patients would have to be counseled about the effect of the management on their voice and about the potential for malignant progression of their lesions. The best scenario would be a one-stage surgical excisional biopsy of the entire lesion. This would remove the whole lesion without a need for any second stage surgery, will provide the pathologist with all the available material so that he could reach a proper diagnosis and grade the lesion, and also would not affect the intermediate and the deep layers of the lamina propria so that the effect on the voice would be minimal. The excised lesion should then be properly orientated before sending it for pathological examination, marking where is anterior, where is posterior, lateral, and medial. If the lesion is confined to the epithelium and does not have any signs of deep invasion, then a complete excisional biopsy could be achieved as a one-stage procedure, ideally with a carbon dioxide laser. The UK consensus statement on the management of laryngeal dysplasia favors excision biopsy of the laryngeal dysplasia lesion by the use of carbon dioxide laser, although cold steel excision can give comparable results. The benefits of using carbon dioxide is a better control of the surgical field and less bleeding, in addition to precise incisions. The use for laser to ablate the lesion rather than excise it is discouraged, as it would have collateral damage to the lamina propria and the voice, and will also destroy material that can be useful for histological examination and grading of the lesion. Vocal fold stripping is not recommended. If the lesion is primary, that it is a new lesion with no previous history of recurrence, then the use of radiotherapy for the treatment should be offered only with discretion, only in very selected cases like poor access and visibility of the larynx, or when the resection has a high risk on a patient with poor health. Currently, the only indication for open partial resection and biopsy would be a very inadequate exposure of the lesion by endoscopic route. In new laryngeal dysplasia lesions that had not been treated in the past, the most important factor in deciding the type of management would be whether the lesions are localized, whether they are single lesion or multiple localized lesions, or whether the lesions are widely spread over the surface of the vocal fold. If the lesions are localized, whether single or multiple, then they can be excised completely in a single stage type of surgery. Each of the excised lesions would be marked and orientated. But if they are widespread and confluent, then complete excision may not be possible in a single stage. The lesions would have to be mapped and staged. After mapping the lesion, a part of the vocal fold epithelium would be removed with some of the lesions, and a second stage may be required at a later stage. Of course, the general fitness of the patient will play a role in the decision making. The management of persistent or recurrent laryngeal dysplasia lesions would depend on two factors: whether the lesion is localized or widespread, and whether the lesion is low risk or high risk. If the lesion is localized and low risk, then the management is re-excision. If the lesion is localized and high risk with severe dysplasia or carcinoma in situ and recurrent, then the management should be similar to excision of a T1 laryngeal carcinoma with subligamental cordectomy, a type 2 type of cordectomy, or higher if needed if there is invasion deeper to the ligament layer. But if the lesion is widespread and low risk, the management would depend on weighting the benefits against the risks. There are risks involved with excision of widespread lesions on the voice, and the patients can be either observed for a while. If the lesions are not progressive, then they can be observed for further periods. But if there is any fear about progression of the lesion, then the patients may have excision, surgical excision of their lesions. But if the lesion is persistent and high grade and widespread, then the patient should be offered radiotherapy. There are other indications to consider radiotherapy that we're going to discuss later in this presentation. The outcome of these treatment modalities were investigated by a recent meta-analysis that showed that the local control rate for radiotherapy is high at 93 point something %, followed by carbon dioxide laser excision at 80%, and then vocal fold stripping at 77%. The differences were statistically significant. The ENT UK guidelines for the follow-up frequency and duration for laryngeal dysplasia patients are based on two factors. One is whether the lesion is low grade or high grade, and two is whether the patient have continued any risk factors or stopped smoking and alcohol, for example. If the lesion is low grade and the patient has no risk factors, then he can be followed up for 6 months. But if the lesion is high grade, or if the patient continues to smoke or drink, then the patient would be reviewed in the same way like a T1 carcinoma of the larynx. And each examination, he would have laryngeal endoscopy, whether flexible or rigid, and a color photo would be obtained and documented in his notes. The patient would also have a neck palpation in each visit, and he will be asked whether he still smokes or drink, or whether there is any other risk factors. The two recommended techniques for adequate excision biopsy of laryngeal dysplasia are either a type 1 subepithelial cordectomy or a type 2 subligamental cordectomy, depending on the depth, the extension of the lesion. If the lesion is confined to the epithelium with no invasion in the depth, and after injecting saline into the subepithelial rhynchus space, the whole lesion is lifted off the vocal fold ligament, then a type 1 subepithelial cordectomy is the preferred technique, in which the epithelium with the lesion in it and part of the subepithelial layer, the rhynchus space, sparing the vocal ligament with the intermediate and the deep layers of the lamina propria, would be the preferred technique. It does not have to extend in the entire vocal fold length from the vocal process of the arytenoid to the anterior commissure if the lesion is confined only to a small part. By lifting the epithelium by saline infusion, the accuracy of detecting any depth of invasion is raised from 60% to 90%. But if there is doubt about the deep extension of the laryngeal dysplasia lesion beyond the laryngeal epithelium, like if there is loss of the mucosal wave on stroboscopy, or if the saline infusion into the subepithelial layer intraoperatively fails to elevate the lesion completely off the vocal ligament, then the recommended technique would be a type 2 subligamental cordectomy. And this, not only the epithelium and the superficial layer of the lamina propria would be excised, but also the intermediate and the deep layers of the lamina propria, forming the vocal ligament. And if required, if there is extension into the muscular layer, also a strip of that muscle would have to be excised. This is the type 2 subligamental cordectomy, which is the preferred technique for microinvasive carcinomas and for recurrent, either severe or carcinoma in situ recurrent laryngeal dysplasia. And finally, if there is any role for radiotherapy in the management of laryngeal dysplasia, radiotherapy should be considered in the following circumstances. If the patient had 2 or more recurrences, if the patient continues to smoke, if the patient has high risk of anesthetic problems, if the patient has some difficulties in laryngeal exposure or access in endoscopic laryngeal surgery, if the patient prefers to have radiotherapy, and in the patients who have persistent or recurrent widespread severe dysplasia. By this we come to the end on this presentation on laryngeal dysplasia. Assalamu alaikum.